they learn that they have a child with a craniofacial difference, what do they need to do so that they have the best outcomes possible? And we know this is a journey of a lifetime. myFace is really aiming to start at the beginning so that we can identify and address what it takes to set a family up for success in this journey. So tonight's program, the format is going to be, we're going to hear from an expert perspective about prenatal counseling. Then you're going to hear from a wonderful family and their experience of what it was like for them. Then we're going to talk a little bit about the role that myFace can play in addressing this need. And then we're going to open it up to this group to ask questions, share ideas, and think about, your perspectives on what it is that we need to do in order to address this need. It is my deep pleasure to introduce Dr. Thomas Imahia-Rabo from New York Presbyterian Morgan Stanley Children's Hospital, where he is the co-director of the craniofacial team, along with Dr. Jeffrey Asherman, and just a little bit about how their team works. It's a group of healthcare professionals with a wide range of specialties and expertise. They meet on a monthly basis for their multidisciplinary clinic. They see patients regardless of their ability to pay, regardless of their insurance. The team then provides a report that gets sent to the family as well as the primary care physician and any referring providers. And so they just do terrific work at Morgan Stanley Children's Hospital. And joining Dr. I are two very special guests, Adrian and Jonathan Stack. And I'm going to let Dr. I do a more in-depth introduction of them. And they'll talk a little bit about their son, Landon. And then I also want to introduce you to Natalie Travares, who is the team coordinator. And Natalie has been instrumental in working with me in terms of our Welcome Baby program, in terms of our COVID-19 gift card program. We were able to distribute some of our gift cards at New York Presbyterian, which I'm very happy about. So these are our guests who are going to be with us tonight. So I am now going to turn it over to, we call Dr. Imahia-Rabo Dr.
Stephanie, thank you so much for that introduction. Each time we're just sort of beginning what I hope will be a long and fruitful relationship with myFace. But I have to say already that every time that we've met or spoken, or I've had the opportunity to meet more members of the myFace family and the myFace board, I come away impressed and excited about the possibility of being able to help more families. As Stephanie alluded to, my name is Thomas Imahia-Rabo. I am the director of cleft and craniofacial surgery at New York Presbyterian Hospital in the Morgan Stanley Children's Hospital. I've been there now for, well, in one way or another for almost 13 years, but in my current role for about 7. What I wanted to do this evening was to start off with a little bit of a talk. I don't want this to turn into a lecture. I wanted to start off with a little bit of a talk on a topic that is near and dear to my heart and also become a really critical portion of my practice, which is prenatal counseling for patients and families who have had a prenatal diagnosis of cleft lip and or cleft palate. I want to try to keep my background remarks and things short enough so that we can have more of an open conversation following this. But what I thought that I would do was to talk a little bit about cleft lip and palate background facts. I know this group is well aware of much of that data, but just as a foundation for what we would then talk about. And then I want to spend some time diving into prenatal diagnosis of cleft lip and cleft palate and prenatal counseling, and sort of give you guys a reflection of what I think are the important aspects and valuable aspects of that prenatal counseling, and how it's actually done, at least from my perspective and experience. And then I want to finally finish up with some data on, what can we say are the quantifiable impacts of this prenatal care that we are giving to families. And then from there, I want to segue into, the people who in my mind teach me more than I, give them, which are the families that we take care of. And I'm very fortunate to have Jonathan and Adrian Stack with us. this evening to sort of share the familiar perspective on what it's like to go through all of this, which I think will be very instructive and informative for everybody, including myself. Um, so I'm going to just jump right in because, again, I want to just sort of stick to time. These are facts that I'm sure that the team is aware of. Cleft lip and palate is one of the more common craniofacial diagnoses that a family or a child can be given. We know that at least 1 in every 1,000 live births results in a child that has a cleft lip or cleft palate. Some studies will say up to every 1 in 700. And we know that this is an entity that has a very wide diversity of presentations. Children can have a cleft lip and palate together. They can have a cleft lip alone. They can have a cleft palate alone. And the majority of cases will be isolated, but up to almost about 30% of children will have some other associated congenital malformation, which may or may not be associated with a genetic syndrome. And so you're really talking about a multifaceted diagnosis that has a wide range of presentations. But at the end of the day, all children need and do better with excellent medical care. One of the things that I still think is the unanswered question for cleft lip and palate is, how does it happen? We know that this is a multifactorial process. There are certainly environmental factors which can impact the intrauterine development in the craniofacial skeleton. These are things that you would suspect: tobacco usage, alcohol. We know that there are some factors which are protective against, let's say, the development of a cleft lip, such as folic acid supplementation, which is going to be part of most routine prenatal care. But for the most part, we don't have a definitive answer on why some children get a cleft and some don't. We still think of this as an isolated and typically sporadic event. Certainly, there are some genetically transferred scenarios where there is a familial history, but that's going to be a paucity of cases, probably about 16%. 84, almost 85% of cases are going to be sporadic in nature. The normal cleft lip, we are thought to occur during the 4th to 5th week of gestation, and the palate is going to occur during the 6th to 8th week of gestation. And we know this from ultrasound studies, which tells us that we can see these things intrauterine. That's really important because it gives us an opportunity to make this diagnosis prenatally before a child is born. And one of the recurring themes in my practice and in these remarks this evening are that the sooner that we know about something, the sooner that we have an opportunity to begin to intervene, the more definitively we can help to shape what's going to happen next. This is a paper by one of my colleagues, Arun Gosain, who's at Lurie Children's in Chicago, talking about 30 years of prenatal cleft diagnosis and what have we learned. And what we're finding are several trends. Number one, more and more patients are being diagnosed with their cleft lip or palate, or finding out about that diagnosis prenatally. If we looked back 30 years ago, maybe only about 10 or 15% of clefts were diagnosed prenatally. Now it's going to be 90 to 95% with certain regional variances. So that's going to be the vast majority of families finding out about this before baby actually comes. And when you survey families, you find some consistent themes, which is that families prefer to know prenatally, and they prefer to be given as much information as possible about their pregnancy and their child. This is a study that I published in the Annals of Plastic Surgery a couple years ago, looking at how good are we at detecting cleft lip and cleft palate using both traditional ultrasound and now more sophisticated methods such as fetal MRI. And what the data simply shows is that at this point in time, we should be able to pick up almost 100% of cleft lips and probably on average about 92% of cleft palates using a combination of ultrasound and MRI. And the fetal MRI has become a routine tool as part of my fetal workup for children once we have a prenatal suspicion. But cinching the diagnosis or finding out about the diagnosis is really just the beginning of what needs to occur. Um, we know that getting this diagnosis intrauterine can have a tremendous impact on the mother and the family, the expecting mother and the expecting family. This is a survey study that was done in Germany that asked two-part questions. The first question was, once a prenatal diagnosis was made, where did the family seek information? And the second question was, once a prenatal diagnosis was made, what was the family's response to that information and to the diagnosis? And so the vast majority of families are going to get information from their OBGYN or some craniofacial surgeon who they may or may not be referred to. But interestingly enough, a majority of families also sought information on the internet, which makes sense in this day and age. And the sources that they got were very varied, from Facebook to support sites, um, to organizational sites. And the families rated this information um, almost equally as good as being good information and also being bad information. Um, and so, what does that leave families with? When you ask families what are their reactions to getting the diagnosis prenatally, the two most common responses were fear and despair. So just think about that as an expecting family getting this diagnosis prenatally, searching for information, and being left to feel fearful and some degree of despair. Um, and that brings me to my first point, which is that I really, really believe that the prenatal counseling, which should follow a prenatal diagnosis of cleft lip and palate, is our first actionable moment when we can start to affect a family's feelings, emotions, and response to their expecting child. And there's good data to suggest that um, early prenatal counseling does have an impact on postnatal care. This is studied by a colleague by the name of Albert O, who's at Children's National Hospital in DC, talking about coordination between the craniofacial team and their maternal fetal medicine department. And without wading into all the details, some of the very obvious things that they found were that if there was a prenatal referral made for counseling, postnatally, the baby was seen more quickly by the craniofacial team on an average of about 21 days later, and also was able to receive pre-surgical orthodontia or pre-surgical molding or setup much quicker as well. And we know both those things are important for the postnatal course. So having a well-coordinated plan where prenatal diagnosis is followed quickly by prenatal counseling and the introduction to a appropriately resourced and sophisticated team is really key. So what do we do during prenatal counseling? There is actually no great data on how to do prenatal cleft and craniofacial counseling. I think that there are certain key elements that I try to weave into what I do with my families. I've given talks on this subject to different maternal fetal medicine groups in the tri-state area. There's a very significant variation in what may happen at different institutions. This is my version or my take on the prenatal counseling for cleft lip and palate that I wanted to share with you. I think there are certain key elements that we should try to do once we meet a family prenatally. The first one is to make sure that an adequate prenatal workup and screening has been done. As we mentioned, 86% of cases are going to be isolated and sporadic. We want to try to give a family a sense of, are they in that 86% where they have a healthy child that has a cleft? Or are they in that 15% where there's actually something more complicated going on? And there are different elements to the prenatal workup. As I alluded to earlier, I like to do fetal MRI. It gives us a look at the craniofacial anatomy. It also gives you a look at the CNS system. We include things like prenatal genetics, prenatal echocardiogram. These are all important elements of the prenatal workup that I won't go into more detail about here. The other elements are things that are going to happen during the counseling efforts. The first one is giving families education regarding cleft lip and palate. We already mentioned studies have shown that families, the number one thing that they're looking for is information. And so we want to try to guide them to the correct information. And I'll talk about a little bit how I do that. The next element is what I call demystifying the cleft. You can imagine being a family expecting a child that has going to have a cleft lip and palate, having never seen another child that has a cleft lip and palate, which is probably the most common scenario that a family is faced with. So what do? You go online. And unfortunately, I think of online as a very much a mixed bag. You're going to see the best of the best and the worst of the worst. And families really are then left with a feeling of they don't know at all what to expect. And so there's a process of demystifying the cleft that I'll go through how I go about that. And then the final point of the prenatal counseling should be to begin to build a familial support group and connection for families, between families. And if I'm being honest, it's a place where I feel like uh, my team probably has the most work to do. We put efforts towards doing it, but I think we could do more. And it's a space where I feel like an advocacy group like myFace really could play an important role. So we'll talk a little bit more about that in a minute. So what do I do when I meet a family? After I think that the adequate workup has either been put in place or is done, I want to talk to them about what we can do to treat a cleft lip and palate. Because I think the first thing that a family is looking for is, well, quite frankly, hope. They're looking for hope that there is still the opportunity for their child to live a normal and healthy life despite this diagnosis. So how do we let them know that that is actually, in fact, the most likely scenario? I begin by giving them information as basic as what is a cleft? Is it a unilateral? Is it bilateral? What does the palate mean? But also mapping out for them the fact that we have guidelines and treatment timelines and processes put in place that there's information behind it, there's research behind it. There are good ways for us to go about treating their child and trying to give them some expectations of what is 0 to 3 months going to look like, what is 3 to 6 months going to look like, what is 10 to 14 months going to look like, and what is it going to look like beyond the school age period into early adulthood, because we know that this is sort of a lifetime journey. And I think that that's the first thing that a family wants to know. They want to know, what is this going to entail for them? At the same time, I do also want to prepare them for some of the common challenges that we may see in a child that has a cleft lip or cleft palate. So we present them data about issues with feeding and weight gain. My parents will tell you, they hear this all the time. I say, you're going to have two challenges right at first. The first challenge is going to be that you're going to have a new baby. That's always a big challenge. I've been through that 3 times. I know how hard that is. The second challenge is going to be having adequate feeding and weight gain, despite the diagnosis, whether it's unilateral, bilateral, lip only, lip and palate, it doesn't matter. That's always our first challenge because we cannot do adequate surgery without adequate weight gain. So we go through the data on that, and we go through strategies on how to make that successful for them. These are children who I've taken care of that ended up getting feeding tubes. And I try my very best to prevent my children from getting feeding tubes. And in fact, most children that have clefts won't need feeding tubes. I had one family that told me that they found that online that their child had to have a feeding tube, which is absolutely not the case. So we give them information on adequate feeding strategies. We give them information on the specialized cleft nipples and bottles. We help make early connections with our speech and feeding colleagues that are an adjunct part of our team. Again, so that they know, yes, there's a challenge there, but there's a solution that we can offer. We talk about our monitored feeding program that we do in conjugation with their pediatrician. Again, making them well aware of the fact that there's something that we can do about this. We talk about other challenges such as reflux. This is another paper that I published about rates of reflux in children with clefts. We talk about how we treat those and meet those challenges. I'm very honest with them about surgery, the need for surgery, the timeline for surgery, what surgery can do, and where surgery may fall short. For instance, we know that if we survey children who are in early adulthood, They'll tell you that probably the area that they would most want a revision in their cleft is around the nasal anatomy. That's something that we're very all aware of that take care of these children, and the upper lip area as well. And so we discuss that, but we then discuss strategies that we can use to try to help prevent these things. We know that the initiation of pre-surgical nasal molding or orthopedics, whether that's NAM or simple taping, can certainly reduce the need for later revision surgery in children that have cleft lip and cleft palate. And so we talk about that data and we talk about those strategies and we connect them. Well, at least we introduce to them the concept that once baby is here, we will assess the need for some type of early pre-surgical setup. And if the need is there, we can connect them with that. And then I move into the aspect of demystifying the cleft. And what does that mean? Well, the way that I go about that is that I want them to know that there is a tremendous range of what a cleft can look like on a child. But I want them to see the whole range from small to big, from wide to skinny. And I want them to see the results before and after repair so that they can understand no matter what it is that we're presented with, we can take care of it and we can get consistent results. And I think that that's a way for them to start to frame in their mind, okay, I have seen a baby that has a cleft like this, and I know that there is an answer for that child. So we will go through, if it's a unilateral, we'll go through what does a microform cleft look like before and after repair? What are the elements that repair tries to do? We're trying to realign the white roll. We're trying to balance out the Cupid's bow. We're trying to make sure the mucosal tangent is even and natural. We're trying to address the nasal anatomy, that this is not just a cleft lip, even though we call it cleft lip, it really should be termed cleft lip and nasal deformity, and how we go about doing that. We move into an average incomplete. What does that look like? What does the scars look like after repair? What can we do in this day and age to optimize or ameliorate scars after repair? We show what does it, this is a thin incomplete, this is a wide incomplete. This has a little bit of nasal involvement, this has a more significant amount of nasal involvement. Despite that, we want to have consistencies in the approach and let them know that they can feel reassured that on the other side of it, that the child is going to have natural looking anatomy. This is an incomplete with a Simon Arts band. This is another version of that. Very, very significant nasal involvement. I show them pictures like this where maybe the surgical scar is a little bit thicker. Those first three, you could barely see a scar. This one is more significant because I want them to see that that is part of the deal, that that may be something that they need to, or we need to address. We show them wide clefts. We show them complete nasal, lip, and palate. We show them what those results can look like. We show them super wide clefts, children who come to us at an earlier age without the benefit of any pre-surgical orthopedics or NAM. And we show them what that typical results may look like. And we discuss what are our strategies, let's say, for going back and doing a little bit of a nasal revision potentially in this child. We do the same for bilaterals. We can show them the full range, bilateral incompletes or with a microform on one side, bilateral incompletes, about 50% of the lip affected, incompletes with a complete on one side and an incomplete on one side with a Simon Arts band. Another category is similarly incomplete with a complete on one side, complete together without the benefit of some pre-surgical orthopedics, complete together with the benefit of pre-surgical orthopedics. These type of pictures are not necessarily meant to be a who's who of my best results. These type of pictures are meant to be representative of what the full range of clefting can be. And each one, there's a mental note that I'm making on some aspect of results and expectations to give a family. Because at the end of that, what I really want them to take away from is that I have been connected with an individual who has seen the full spectrum, has experience with the full spectrum, and has answers for me. So I don't have to go and look for information or misinformation on my own. And I think that that gives a family some insurance that that they're going to be able to get through this journey together with us. We certainly talk about our craniofacial team and all of the multidisciplinary services that are connected there. And they obviously meet with our craniofacial coordinator. And I think that these are all the minimum elements of a complete prenatal counseling session. But there is, as I mentioned in the setup slide, something that I think we should be doing more so, which is trying to launch from the medical into the sort of metaphysical, and trying to help connect a family with other families to provide supports beyond just what the medical community is going to give them. Because again, if families are getting this diagnosis and they're feeling fear and despair, yes, some of that is related to the medical consequence of what's going to happen. But I think some of that is just not having the knowledge of what life with a child that has a cleft really entails. And although I'm a provider who has gone through this journey from a medical standpoint, hundreds or if not thousands of times, um, I'm, I'm not a family that's having gone through it in that intimate way. And I think that that provides them with another level of assurance and information. So we do talk to them about our craniofacial cleft lip and palate team day. This is an event we put on up at Columbia where we connect families. It's just for one day, but every child that's there has had a diagnosis of cleft lip and palate that we've taken care of. It's a family-centered event. There's games, there's entertainment, there's face painting, it's themed differently every year. Natalie's been instrumental in making this happen. And it's just one of our efforts in trying to connect families together. We certainly give out phone numbers and lists of families to connect to, but we know in this day and age, sometimes it's hard for people to want to pick up the phone and call someone that they've never met. But what we want to try to give them a sense of is that we have a community, a large community of families and individuals that are going through this, and that there is going to come a point where they're able to move past this diagnosis of cleft lip and palate. And they're going to wake up one day and they're going to look at their kid, and the first thing that they're going to think about is not their cleft. And I kind of assure all the families that we will get to that point. I can't tell them when it's going to be on their individual journey, but I know that we get to a point where we have smiling faces again. What does the data say about prenatal counseling as I'm wrapping up here? Um, the data says that it does have an effect on postnatal care. We know for a fact that children who, for instance, are exposed to prenatal counseling for cleft lip and palate have less of a need for admission to the neonatal ICU, and certainly lower rates of failure to thrive and feeding issues. We also know for a fact, these are some of my colleagues from Los Angeles at Children's Hospital LA, we know for a fact that families who have undergone prenatal counseling will have lower rates of maternal postpartum depression. Because again, I think that it gives them time to begin preparing themselves for what is to come. But I still think that we have done a poor job of quantifying how important the non-medical aspects of what we're doing are, and that's an area for both collaboration and research. And so to sort of give some of that familiar perspective, we've invited Adrian and Jonathan Stack here to talk to you tonight. They are one of the families that I have taken care of. I took care of their son, Landon. I feel like I have seen the many faces of Landon, even though it's only been a short amount of time, from the pre-surgical newborn baby face to the immediate post-surgical I'm still healing swollen face, to the first time he came in a little tuxedo face, to the I'm getting teeth and I'm starting to drool face, and now to the I have more hair than Dr. I will ever hope to have face. And it's awesome to just go through and see this child and see this family grow and change, and to be a part of that. And now when I talk to the Stacks, not necessarily the first thing that we talk about will be Landon's cleft. And that's amazing to have gotten to that point already. Adrian and Jonathan are amazing individuals. They're both educators, they're both teachers, and they are one of the families who I love to connect other families to, because they are open and they are honest about their journey that is still ongoing. And so I thought that they would be great people to sort of talk to you tonight about what this is like from the other side of the mirror. And with that, I'm going to turn it over to Adrian and Jonathan. Thank you.
So we've just been getting choked up the entire time, as not only to see Landon's pictures, but I think also to just recall, as Dr. I took all of you through the steps of how he guided us through this process, and just to recall all of those little steps in the process, certain pictures of other children that we remembered, certain statements and phrasings that Dr. I had used, at different moments in our journey. So it's definitely definitely a little of an emotional moment.
Yeah. I just want to show, this is a more recent, he has more hair in this photo, I'm so sorry. But you can see, there's a little bit of a glare, hold on. So you can see, like, he's just stunning. He's just absolutely stunning. And it was very emotional to find out that he had a cleft lip and cleft palate. He's our third, and there's a bit of an age gap between our second and Landon. Our second is 9. So, we were ready to have this baby, and our older 2 do not have any cleft lip or cleft palate issues. I did have a cleft lip, so there was always that concern for that, but it was never even on my mind, honestly, during the ultrasound, because I had 2 that had no issues. And it was so devastating, because we were told that there could have been other things wrong with him. And Jonathan, within 2 days, had an appointment. He found Dr. I, and he plugged along in booking appointments for us right away to kind of get the ball rolling, to see what was in store for us. And I'm sorry.
Well, when we got the information, I think part of what was devastating as well is when we were meeting with the technicians at during the ultrasound. I mean, within 5 to 10 minutes of the conversation, the doctor we spoke to at this facility, it was talking to us about termination and what states we would need to travel to. I think that's one of the things that, becomes part of this reality too, this conversation, because that's what was then, hitting us even harder, thinking about, wait, this is part of our reality now, this conversation. How does this impact our marriage? How does this impact our children? How does this, impact this being? What kind of quality of life can this baby have? And all of these things are swirling in your head. As we're speaking now, I look ahead in my dining room, is on the other side of this camera, and I remember doubling down in the dining room in tears, as all of this is happening simultaneously. And I had reached out to St. Peter's here in New Jersey. We had an appointment with CHOP, and Dr. I was our second visit. And I cannot tell you, somebody in a room somewhere said New York Presbyterian, that like they say Columbia, they said something, I don't remember, because again, in that moment when we were getting this information, we were just so confused when we had the ultrasound. And then we went to see Dr. I how many weeks later? It was quick.
It was a week after the ultrasound. And we were sitting in the waiting room, and there was a little baby sitting there who had clearly just seen Dr. I for surgery. She was still very puffy, but I wanted so badly to be in that chair, to be on the other side of it, because I felt like it was this path I could not traverse at all. And I remember we were driving home from Dr. I's visit, and we looked at all of those photos, and he said all of those perfect things, because he put our mind at ease. And I felt like I was committing to marriage to Dr. I, because I turned to Jonathan in the car and I go, he's it. He is it. His bedside is like no other person's, and he makes you feel, as a parent experiencing this, like you are the center of his world, and that your baby, when your baby is 3 months old and just a little itty bitty thing, he's going to take such good care of your baby. And all of those talks and emails and sending photos, and Natalie is so instrumental in all of this too. She answers my texts, she answers my emails. She's there to put all of those pieces together. So without Natalie, like, things just don't run. And
we are not social media people. We have no Facebook.
Yeah,
we have no Instagram. We reject that outright. I'm a social studies teacher, and I think that this is the bane of human existence at the moment. I'm not. So we do not engage. So for me personally, you walk into this and you have no idea what the next step is. It feels completely insurmountable. This is not a conversation that anyone wants to have. People don't talk about this at cocktail parties. I don't even, we've always taken it that it is part of our reality now. We tell everyone about our experience. We tell everyone, because I'm hoping that someone somewhere goes, oh my gosh, I know someone who had a child, they had a Dr. I, you have to, I want that to be out there, because what I felt that Dr. I gave us, was a plan of action to follow. That there was a framework that we could now follow. And that framework was open, and it was honest, and it was clear. One of the simplest things for me personally was when Dr. I talked about the pre-surgical work, and
he did a very good job.
And I remember, and I'm going to say, use layman's terms to explain this, I tape him up and put little tape on him, little hooks in his nose, and I'm taping him up. And Dr. I had said, he goes, listen, you can give me an extra millimeter, something along those lines to kind of just tighten everything. Dr. I clearly did not use that terminology the way I'm doing it. But I mean, I woke up every morning and that was my reality. I would tape my son's face together. And it's the greatest thing I've ever done in my life, because that was my reality every morning. Dr. We had to try different solutions, and Dr. I made a little template for me to follow. So I would cut these, and I would spend every week, I would cut a bunch of these out. I would sit there and I would cut out about a dozen for each week, because after a while his face got stronger and it would snap. So I would cut them all out, and I had everything sitting there. I had a little system to make it, but we had a plan, from the very beginning. You get to then take ownership in the role as the parent, as this is my goal. This is what I'm going to do. I can't do anything else. I made the phone call to make the first appointment, and then I taped this baby up, and then I hug my wife, and that's my job. There's nothing else for me to be able to do with this. But then you're the one that went through all those other steps.
So I'm so grateful for Dr. I and Natalie sharing that list of phone numbers, because I was adopted. I had a cleft lip, all those many years ago. I know I only look 21, but I'm not. I think it was probably very isolating for my parents, and I was very fearful of that, because like we said, I don't do Facebook or any of that. So when people say, well, just go find a Facebook group, and I'm like, but I don't want to go down the rabbit hole of Facebook just to get in a group. And with the list of phone numbers, I reached out to every single one, because I will open up to anybody and talk to anybody. And one person called me back. And that person, her name is Muji. She was a goddess when I was pregnant. And she responded to every text. We talked on the phone. She asked for photos. She sent me photos of her daughter. She reached out the day Landon had surgery. And to have that connection, not just for someone that was in my position at one point, but like I said before, like that family sitting in the waiting room, to talk to someone on the other end of it and to hear the praise of who Dr. I is and what he stands for, and the man that he is for all of us as families. It was so nurturing. it was so wonderful to be able to, and I don't like to cry, but to cry to someone and to get all of my questions out and fears out, and what if my baby can't eat? And that prenatal piece is so critical, not just to know about the health of your child down the road, but for my own mental health, to be able to calm my nerves. And I mean, the 4 days, I said this to Dr. I last week, the 4 days after we had the diagnosis where we were told there were a lot of other things wrong with Landon, I didn't go to work for 4 days. And if you know a teacher, to not go to work, you have to be in a bad way, because for a substitute, it's a mess. And I just couldn't get out of myself. And to have that outlet and to hear what worked and what didn't work and what surgery's like and what recovery is like, to hear all of that on the front end just allows you to emotionally prepare for all of it.
And I think, for both of us, it's, I think we're both talking about two different ways that, our fears were assuaged. You're talking about, not that you didn't embrace the Dr. I's approach and the organization, but for me, I needed to hear organization. I need to hear a step-by-step process. We do this, then we do this. Expect this, then expect that. And I think you embrace that. And then the opportunity to have those connections too, more of those emotional connections, where you can make that personal connection with those other people. I think that, if you have that two-pronged impact, I think that's what makes it a much more approachable and organized situation. Because again, you begin this, and we were old, we're older parents at that time. We were 39 with these two parents, with this child. We were 29 with our first. We had two, children who were happy and healthy, and everything was perfect. And then this, it's like a car crash. It's a car, you're speeding along the highway of life, and it's a car crash. And you expect the worst until somebody tells you, don't expect the worst. This is the truth. This is the reality. There's the good, there's the bad, but this is the reality. And, here we are, there's nothing I would have done differently. There was no different step I would have taken. There's no doctor I would have ever asked for, no team I would have ever asked for, because our baby is a happy, healthy, ray of sunshine.
So great.
And, he's just,
so great.
We're very blessed. We are very blessed, that we have been given the opportunity to work with Dr. I and the entire team. We're very blessed to have this amazing baby. And, we're blessed to be on this side of the reality. And I just, my hope is that, more people get to hear these stories, and more people get to expose to this, because it is not, it is not, there's no finality to it. I don't know.
Well, I wanted to enjoy my pregnancy. And when you're pregnant, you want to enjoy all of the things about being pregnant. And when you have something on the other side looming, multiple surgeries, to have the connection to a prenatal team to help, what you said, assuage your fears. It's for the betterment of the mother, for the baby in utero, for you to be in the right state. And I think whatever can be done to help families. I mean, we brought our older two children to meet Dr. I'm like, come meet Dr. I.
We're like, this is the man that's going to save your baby
Yes.
brother. This is we brought them in to meet him.
And it is a family commitment to that baby. And to have everyone involved and everyone on board, my children were excited to send Dr. I a holiday card, like make sure he gets it so he can see us, because he is a part of our family. And it's important for everyone to be in the room. Oh yeah, I'm honored to be speaking here, and Jonathan would say the same, because there's nothing that we can't say to stress the importance of this prenatal care families for so many different reasons. So.
And then I'm sure all of you will have far more questions for Dr. I than us, but for us, there are no questions that are off limits or out of bounds or too sensitive. You know, if there's any questions to ask us, which I'm sure there won't be too many, please don't hesitate on our end.
Well, Adrian and Jonathan, I want to extend my deep thanks for sharing your story. It's a very personal story, and you just told it with love and compassion, and we just are so appreciative. And of course, Dr. I, we know you're a rock star as well as Natalie. So this is a great segue. I want to take just a quick moment because I think this is where we get into the metaphysical and think about what can myFace be doing in order to support families like the Stacks, and how can we make sure that we provide what they need throughout the journey and then get them prepared to be on the other side. So I'm going to just very quickly share my screen with all of you. I'm hoping you can see this. Yes, a high sign from somebody. Yes.
Yes, we can see it.
Okay, so this is just, so with what we've learned today, what are we doing? This Salon Series that you're participating in now is going to be offered again with the support of our development committee. And we're going to bring in a group of interested supporters, people that we know have interest in this topic, and we anticipate would be willing to think about with us about how to support building programs and services around prenatal counseling. We will be hosting a Transforming Lives webinar in January, on January 28th. Pat Chabaro and Margie Moratzis are going to be speaking about in a more public setting what Dr. Imahirabo spoke about today. And then finally, we're contemplating developing an actual virtual support group program that would be meant for parents, designed for parents, that would be roughly 6 to 8 weeks, that would allow them to go together through this program. I think something like 5 to 8 couples would work together through the entire process, understanding the journey at the same time. We would provide the tools that they need. We would put a formal curriculum together so that they can actually go through the process together. So this is an idea of what we're thinking about as we go forward. So I wanted to present that to you all. And I wanted now to take an opportunity to open the floor, whether it's to ask questions to Dr. I, or to Adrian and Jonathan, or conversation amongst yourselves about how can myFace be the metaphysical side of this prenatal counseling.
Well, I would love to start by saying thank you to the Stacks for your honesty and your emotion. And I have 2 out of 3 of my kids who are now grown, 21 and 20 years old, that have gone through that and bilateral cleft lip and palate and treated at NYU. And I have to say, I was also born with a cleft lip, and just a unilateral cleft lip. My children were born with a bilateral cleft lip and palate. And I have 3 children. So I have an older one that was born with a bilateral cleft lip and palate. So she was my first one that was born. And I was devastated. And I was horrified that I passed this on to her. But I didn't have a support group, but I was able to, knowing that I had that, or that my child was going to be born with a cleft lip and palate, I was able to do some research. And like you said, there's some bad stuff out there and there's some great stuff out there. And that was, my oldest is 21 now. So that was a long time ago. I'm grateful that there's so much that's been done in this area to open people up to it. So excited about myFace's role in getting the word out and the support that we can give. And because I think the support is so necessary. When a mom is pregnant, whether it's her first child or her 5th child, you're still going through this pregnancy and you have these ideas and these dreams for what you want this child to be. And especially being a parent that had it and grew up with it. And it was a long time ago. I'm 51 years old. But to think, oh my God, I'm bringing a child into this world with the same thing. And no matter how much it's changed, it's still the child's experience of going through life with a cleft. And while it's gotten so much better, I am so excited about the potential of bringing this information to parents. And, I feel like I want to get this out to every OBGYN, that when a child is born with a cleft lip and palate, there's support for them. There's help for them. There's the whole trajectory that Dr. I, that you lay out for them is beautiful, is helpful. It gives hope. And I know from myself, I spoke to 21 years ago, I spoke to a parent that had been literally 6 weeks ahead of me and had given birth and had gone through the surgery and it was like my lifeline. And it was, who I clung to, and I remember that with just giving birth. I remember, I knew in utero that my child was being born with a cleft lip, and at that point there wasn't the technology to know whether or not she'd have a cleft palate, but they suspected she did. But on top of all of the craniofacial stuff, there's like, for many parents, it's just, you have a baby growing inside of you, and it's a beautiful thing, and you should celebrate that. And my heart goes out to you guys for the conversations you must have had about the possibility of terminating this pregnancy, and the knowledge that needs to get out there to help these families learn that it's not a horrible thing, that it's workable, and that it's fixable, and that there's life after it, and there's so many worse things that your child could be born with. And I thank you for your openness, and I really look forward to myFace joining the community and providing an outlet and a support group for these parents, because I think that it's so important and it's so well needed, and it gives hope and it gives life, and it offers so much. And so thank you for being so open and sharing your story.
This is John Gordon. I have a question for Adrian and Jonathan that addresses something that at least is an explicit matter we haven't addressed. I think when people think about cleft lip and palate, I think the immediate thought is to appearance. And the thing that I keep thinking about is the cleft palate part, and the fact that no surgery should be done without weight gain, and cleft palate repair happens between the 10th and 14th month. And I'm thinking about, wait a minute, there's nothing worse than hearing a baby cry because it's hungry, if you're particularly on an airplane and seated next to that baby. And so I guess the thing I would love to just hear just in a moment or two is, there obviously is a monumentally practical issue of how do you get nourishment into your child with a cleft palate, because there's some plumbing issues in terms of where the food ends up going. So in point of fact, is that actually pretty easy to navigate? Or since it's all real time and you got to be feeding the baby every couple of hours, it isn't so, well, I'll leave that till tomorrow. Could you just educate me? Because I've always been fascinated by it and I've never had anybody explain it.
So we found huge success with the Dr. Brown's file.
Which Dr. I recommended too.
Yeah. And in that there's a valve, there's a little, and in Dr. I's presentation, you can see the little blue valve. Yeah. And it just takes some of the stress off the baby trying to suck the milk out. It does a lot of the work for the baby. There's concern about breastfeeding. You will read on the internet that cleft lip, cleft palate babies can't breastfeed. My son did. even though it was a short window, that bonding, I wanted it so badly. And I got my little moments with him, but he was predominantly a bottle fed baby. And it's, you know, the angle, making sure you're aiming it down. Did some formula come out of his nose at times? Yes. And you kind of have to be prepared for that. And it's jarring the first couple times because your exact concern is the baby getting enough of a caloric intake to put on weight? And you just have to keep plodding along and making sure, you know, that he's angled up and you're angling the bottle down. And it's just these tricks that you have to perfect. And it's the same thing when he transitioned to solids. You know, he had his cleft palate repair at 9 months. And it's actually how I eat ice cream, so don't laugh at me. But I take the spoon and I flip it, and that's just how I eat ice cream. I know it's weird, but that's how I got Landon to keep that solid down, because the spoon existed as his palate. And so then he was able to swallow it and keep it down. And that was just a lot of trial and error and figuring out what worked for him, what was comfortable in his mouth, just physically. You know, we are working with a speech therapist. He finally qualified. Yes. So had to fight 3 times for that. You know, but even, you know, I keep saying to myself, whereas, you know, he's going to be 2 in February, he's only had a full mouth since he was 9 months. So him still physically learning, oh, like, wow, when my tongue touches the roof of my mouth, there's something there. And he does not hold back on eating now. He's a great little eater. And even the solids came out of his nose. And it's just, he really kind of just acclimated to it, you know, because it's more, I think, the shock for the baby, or that, you know, that sensation of it coming out. And we just kept pushing him forward and flipping that spoon and angling that baby, and he did a great job. But if you don't have, you know, an outlet and someone to really help you know, like Dr. I, to know the right bottle, because there's so many bottles out there and they're not cheap, you know.
And that was the thing, you know, Dr. I exposed us to different bottle types.
Yeah.
And again, I think we were lucky. Landon had just some, I think, innate abilities. But at the same time, I think what we were also, he is our third. We were very calm and patient. Right. I think something, you know, it's hard if you don't have that level of patience. And it was a very slow process. Mm-hmm. And you have to be prepared. Again, other people would try to feed our baby, and when it would come out of his nose, it would horrify family members and grandparents. Now, you know, they couldn't handle it. It was just too shocking for them. So
I think where the support groups come in, and like this is okay, this is normal, you know, this is what's going to happen, and it helps you become more okay. It's horrible. I get it. Yeah. I lived it, but I think it helps you become more okay with it. Yeah. And the support groups are just so, in my mind, so important to have that, you know, this is what it's going to look 6 weeks ahead. This is what you're going to go through right after surgery. This is what you're going to do a year ahead. And to have that perspective, to me, is invaluable.
Yes.
And I
Thank
think,
you very much.
Oh, you're welcome. Because I think for me, the hardest part, I would not talk about it to anybody. I did not talk about it at work. Everybody thought my pregnancy was fine. Both of our families knew, but I am very private. So someone like Muji, who I could, there's not a lot of commitment there, right? Because we don't see each other at work or cross paths. So to have her was vital for me, because I was keeping everything very pent up, because I didn't want, not that people would, but you don't want people to make comments. As you said, I grew up with a cleft lip.
I think that's very,
I'm sorry?
I think that's very common. And I, as a mom that's had a cleft, you feel a little guilty. I mean, I don't know. I don't want to speak for you. But
Oh, I did. I thought that I brought it on him.
right.
So getting past that piece, and I mean, obviously we're so many decades away from when I had it, and the advancements. I mean, if Dr. I is right, you're going to get to a point where you look at your son and you just see your son. You're not going to see the cleft or the scars or, you know, like the stitching, you know, from the two. You're just going to see him. And we're well past that, where you just see him, and it's wonderful.
Can I ask a question? First of all, thank you both, and Dr. I. Really terrific to meet you and to hear your incredible story. My question is, when did you tell the other children, you know, about their baby brother, and how were you able to bring them along? Because I'm assuming they're fairly young. I think they're 9 years apart, you had said, right? So, you know, they're in that age group where, you know, they kind of want to be with mommy and daddy, but they still want separation. And so how difficult and how did you maneuver that?
So we did not tell them at first. I think we waited until after all of the, you know, like the fetal MRI, the fetal echocardiogram, like just to make sure that the only obstacle in our way to making sure Landon is healthy and well is the cleft lip and cleft palate.
Like we had met Dr. I a few times before we had brought Logan and Lily to meet Dr. I, and I think it was only a little bit sooner than that we had really had the conversation about what was going to go on. Right, like you said, outlining these are the steps that are going to be taken. These are the surgeries that we're going to be having. You know, that this is, and I still think pushing the idea that this is, you know, this is a private conversation. You know, maybe I think I remember saying something like that along those lines. That this is for our family, and maybe again, this is part of that, right? That undercurrent of, I don't want to say shame, but like that you're like, we're not talking about this. This is not what we're talking about. You know, you're not telling your friends, you know, we are going to tell people the way when we want to. Perhaps that was part of it. I don't know. I don't know if I'm speaking for you in that point.
Well, we did say that. We did. I think too, it was for them to, as we said before, to be a part of the process. Yeah. So we're, you know, mama is pregnant, the baby is healthy, but the baby is going to have this journey, and we're all going to be on this journey together. And so our oldest is 11, Logan, and to leave Logan at home when Landon had his first surgery might have been the worst day of his life. He wanted to be there so badly. But even the day that Landon was born, they held him and loved him like you could not even imagine. And it was a very difficult weekend having Landon because our daughter was in a competition, and so Jonathan was kind of away with the kids, so I'm, you know, kind of in the hospital by myself because he was running point on everything. And that, you think giving birth is like this magical moment, but when people are coming in and they want to take newborn photos, you have no idea how hard that is for a mom with a baby with a cleft lip and cleft palate, something so visible. And then to see my two children come in and just want to hold them. It was, I think it was one of the better decisions we've made, where it's making them aware, not shielding them from it. But I watched documentaries with them. There was this great documentary, like the nine months that make us. Everyone should watch that if they have a baby with a cleft lip, cleft palate, because especially if they have children, because it allowed me to show my children, this is what the baby looks like right now in utero. This is when this part of the face didn't form for Landon. And then you can see right away these success stories. There was a family in England. So obviously I love it because it's the British accent, but you're allowing them to see the end result, and so it's not as scary, you know. So that, I think we told them within a month.
So what struck me was when I went to NYU the first time, and I saw a young family, and there was a brother and his younger brother, and his younger brother was getting care. The older brother was acting up. And I just started a conversation with dad, and he was telling me the story about how the family so needed to be in some sort of counseling because they were spending so much time with the younger son that they were just neglecting the older son and not meaning to. And that's when I started really getting interested in the myFace philosophy of the entire family, and how they could help the entire family. I've got 6 children, and I can only tell you that, when one's mad, they kind of all are mad, and then you don't know which one to go to first. So, but I really want to thank you for your honesty, your openness, and I got a chill in my spine right now thinking about how wonderful you are, and how great your holiday is going to be, and mine's going to be a tad bit better that I got to meet you. It's really,
Thank you. Thank you so
really
much.
tremendous, really tremendous.
Bill, you brought up something, and I think John dropped off, but he brought it up before when he was doing his opening introduction. We don't do any counseling, at least I don't do any counseling that includes the children or other children of the family. The counseling is for primarily the mother, but the parents, let's say. And we know that kids' ability to adapt is well beyond that of adults, right? Like, we're so concrete. We know right from wrong. We have judgments that are very ingrained about everything, may or may not be affecting some of the things happening in our society right now. The fact that we also concretely believe what we believe, it's so hard to open to new possibilities. I have found kids to be so adaptable.
Mm-hmm.
However, in this context of this conversation, it becomes clear to me that there is a room for helping parents to understand how to address this with the rest of the family,
Yeah.
with the other kids. And it's not something I've ever talked about. I am, shocked at when we started doing this team day thing and we started getting everybody together. Initially, Natalie will be my witness. I was like, well, it should be the child who's the patient and their 2 parents, and we have to limit it to that. And some of that obviously with space concerns and budgetary concerns and things like that we're all facing when we're trying to do something. And then like 2 weeks later, Natalie was like, Dr. I, that's not going to work. Everybody wants to bring their brother and sister. And I was like, and then there was that moment of like, oh, did I bite off more than I can chew? And then I was like, okay, fine, let's just bring everybody. Bring the whole family. Bring grandma, bring your mother, bring your sister, bring the brother. Because in reality, we are not just treating a child, we are treating a family.
Absolutely.
And it's a familiar journey. And even I forget that sometimes. And in a moment of complete, candor, I brought my daughter to the Craniofacial team day because in part, I wanted her to understand what it is that I dedicate so much time to. And that, there are faces and people behind all of this work. And she's 6, though very precocious and very bright. And she said things, and I explained to her that many of the kids would have had surgeries, and that's just not, that's not the point of it. That's not what we're here to talk about. We're just here to have fun. And she had like some, regular questions like, will they have scars? Will I be able to tell who had surgery and who didn't? Da, 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 da. But anyway, my point is, at the end of it, when we were going home, all she was talking about were the other children and other people that she met and the things that they got to do together. There was no conversation that she initiated that had anything to do with the fact that she had just spent the day around all these kids that had cleft lip and cleft palate, right? Which we think is this very external thing. And maybe that's a commentary on how good our surgery is, but I don't think it's really that. I just think it's the fact that they're programmed to just go with the flow and integrate everything. And we are less so. Somewhere along the line, that programming changes by things that we put on to society. And so maybe we need to give parents mechanisms to help, not just with the child that has a cleft lip and palate, which is obviously the point of the work, but for the whole familial unit. And I don't know that I've really ever put a lot of thought into that in that way. So as always, Adrian and Jonathan, you're continuing to teach me things, and I appreciate that.
Yeah, incredible.
I would say that for myFace, and as we have the board here and we think about just the gaps that need to be filled across the board that are not necessarily going to be filled at the institutional level, but that as an advocacy group, we can develop the programs, the services, the education that will support the incredible work that you do. And thinking about, we're starting at the beginning here with prenatal counseling. The issues carry on, as we said, you said, I said, it's a journey. It never stops. It carries on throughout that individual's life and throughout that family's, participation with that individual. And how can myFace develop the appropriate tools to work alongside New York Presbyterian and other institutions across this country, because there are stories like this all over this country. And what can we do to address those needs? So it's almost, we're 27 minutes past our allotted time, but I think we've had just a brilliant conversation. I don't know if there are any other questions that we didn't get to. I'm certainly happy to take questions, take them back to Dr. I, take them back to the stacks, if that would be helpful. I want to thank you from the bottom of my heart for being here, Adrian, and Jonathan and Dr. I and Natalie, for your incredible work. It is such a pleasure to be working with you, and we look forward to the future. My deep thanks to all of our trustees for your time tonight. You are the best. And with that, I think we'll wrap up. If anyone else has anything else they want to say.
Can I just say just one thing? If there's any way that we could become involved with myFace, we would love that.
I'll be calling you about the Wonder program shortly. Not tonight, but soon.
Yeah. But anything that we can do, we are thrilled to be a part of it.
And we would love to have you as part of our family.
Amazing.
And I love that you're educators.
Yeah.
Oh, thank you.
I love that.
Tell me what grades. History, right?
Yeah, so I teach AP European history to mostly seniors and US history to sophomores.
And then I teach everything to fifth graders.
Fifth graders. Oh boy.
Perfect.
Yeah.
Perfect.
Oh, that's great.
Thank you both of you, because
Stephanie, thank you so much for including us, inviting us, reaching out to our institution. And I still very much look forward to finding ways that we can continue to work and grow together. So again, happy to continue to help, lending a helping hand to anything that myFace has going on.
Thank you.
Dr.
Thank you.
I.
Sandra, did you want to say something? Sorry.
just thank you for your honesty and your openness, and I really appreciate it, and I'm looking forward to many good things coming from this.
Yes, indeed. Hear, hear. Okay, everyone, have a wonderful evening. Have a very wonderful holiday, safe, peaceful, and my gratitude for being here tonight.
Thank you, everyone.
Thank you so much.
Take care.
Thank you, guys. Take care.